Welcome to the October 2025 PD Parlor with Dr. Priya Cardone of UPMC. She is a movement disorders specialist neurologist. We're also joined by Dr. Kusyk. She will be introducing him in more detail in a moment. And this is the second part of a series on deep brain stimulation. Thank you, Dr. Cardone. Please take it away.
Hi, everyone. Happy October. Halloween's coming up, and this is part 2 of my DBS series, which I'm really excited to present because DBS has become very near and dear to me, even though it took a while to grow on me from fellowship and to the time when I started and to where we are today. So I'll go ahead and get started. So let's just review a couple of things from the first lecture series, which is what really is DBS. DBS, as you recall, is a surgical treatment option to help control symptoms of Parkinson's disease, as well as a couple of other diseases such as essential tremor or dystonia. It involves the placement of 2 electrode wires down into the brain. Those electrodes connect by wires under the skin through the neck to a battery pack in the chest, in the upper chest. The electrodes in the brain provide constant electrical stimulation to 1 or 2 sites of the brain to help control the symptoms. So a couple of the requirements to be able to be a candidate for DBS, however, you do need to be less than 80 years old. You have to have carried your diagnosis of Parkinson's disease for at least 4 years. The reason for this is because you need to prove, first of all, that it is definitely Parkinson's disease, but you also are looking in those first 4 years for any signs of a Parkinson plus syndrome. That would be dementia with Lewy body or progressive supranuclear palsy or cortical basal degeneration. Because if you are in one of those categories, your symptoms will progress much more differently and rapidly over the first 4 years as opposed to traditional Parkinson's disease. And if you are in one of those Parkinson plus categories, then DBS could potentially make that worse. We do have to prove that you are levodopa responsive. What does that mean? It means that you have a clinical response to carbidopa levodopa, which is essentially the precursor for dopamine. The way that we prove this is we have patients come in for a visit where they have stopped their meds for usually anywhere between 4 to 6 hours prior to that appointment to ensure that that patient has had a washout of the medication from their body. The time range is variable because there are some patients who are so dependent on it that holding it for 12 hours would be truly very, very difficult, and they only need a couple of hours of a washout to know that they're in their off state. If you are not in that category and you're able to hold it for longer, I usually ask people to take their dose the night before and then don't take any medication the day of that visit. It's the medication challenge visit. You come in off medications or in your off state. You complete the UPDRS, which is the Unified Parkinson's Disease Rating Scale, a standardized clinical physical exam for Parkinson's symptoms. Then you take your medication in the room. I usually make sure people take at least 2 or 3 tablets of carbidopa levodopa. Then you kind of sit and brew for a while until you get into your on state, and then I come back and check on you in about 40 to 45 minutes. As long as you are in your on state at that time, we would repeat the exam, which is on a scale of about 0 to 100. 0 meaning you have no symptoms in any categories. If you get the highest score in every category, your score comes out to be around 100. So we're looking for a 35% reduction of that number. So whatever number you start off at without medication, you have to improve by 35% after medication. And this is not a hard and fast rule. Remember, people who have a lot of tremors, that does not get better with medication. They don't really have that improvement, so their score may not reduce. If you don't have tremors, you also don't get a lot of points to begin with. So there's a lot of caveats to that, but it's just again a guideline to ensure that a patient really is in the Parkinson's disease category. And whatever the dopamine, carbidopa levodopa does is essentially the same thing that the DBS is going to do, but more powerfully, more effectively, and more adjustably. So we do want to make sure that the patient is going to be a good candidate by proving that they already have a response to medication, but we want to have a better response with the surgical treatment options. Your brain has to be relatively healthy looking, so you can't have like history of ton of strokes, bleeds on the brain, a lot of shrinkage of the brain, white matter disease. And if you recall, I did a video on cognitive impairment, and so I might ask Casey at the end, can you drop a link to that video in the comments, or whenever you post this on YouTube, could you put a link to that other video in the comments so that patients can go back and remind themselves what constitutes healthy brain? You cannot have any major cognitive impairment. So patients who start off with cognitive impairment will likely have a worsening of this cognitive impairment after DBS. So that's a strong point to take into consideration when deciding if a patient is a good or medium or poor candidate for DBS. The way that we prove that where does a patient stand in terms of their cognitive status is we require formal cognitive testing. That's done through UPMC Neuropsychology Department by typically Dr. Natalie Sherry or Dr. Luke Henry, or one of their fellows if they're with somebody that day. But they are trained and specifically looking for signs or symptoms of Parkinson's disease, dementia, or any abnormalities that are likely to worsen after DBS. So it's not a hard and fast rule that if you have any cognitive impairment, you're not a candidate. That's not true. What we're looking for is like moderate to severe cognitive impairment that says or indicates that a patient is likely to have a poor outcome after DBS or likely to have worsening of symptoms. The other part of this is that you do need to be relatively cognitively intact because DBS requires a lot of back and forth between the physician and the patient. So it's not just like I'm blindly programming and I know the answer right away. I depend quite a bit on the patient's feedback, whether their symptoms get better, worse, what are the patterns that emerge after the settings are made and changed, because all of that feedback it changes how we adjust the management for that patient. So we do depend on patients being cognitively relatively intact. For patients who are found to have a bit of cognitive impairment and we're a little worried about them, but that patient would still benefit from DBS, you can choose a different site for these electrodes to be implanted. So if you remember from my first lecture, there's typically two sites. Oops, sorry. There's typically two sites of implantation for Parkinson's disease. That would be STN and GPI. For patients who have a bit of cognitive changes, but we still would like to pursue the DBS, the GPI affords a slightly lower risk of having worsening of cognition. So that could be a workaround to any abnormalities in this category. And finally, you cannot have any uncontrolled psychiatric illness. That would be depression or anxiety or bipolar disorder. Again, going back to the fact that we do depend on pretty good cognitive status to be able to give us feedback. And if you have uncontrolled depression or anxiety, that would alter the way you were able to respond to the treatment and provide feedback about how your symptoms have changed at each step of the programming. All right, so I have a quick video just to show just a little bit of like very basic anatomy. And it's actually right here. The part I just want to show is right here. Oh, sorry, am I still sharing my screen? I think we're good.
Yes, we just can't hear it, but I don't know if that matters.
You can't hear that?
No.
Correct.
Okay, so I'll just talk over it. So, and again, Dr. Kusyk is going to go into this likely as well. So this is where the electrodes would be implanted. You would just, going to mute that person. So small incision is made. Electrodes are introduced down through the scalp here. And one of patients' major question is, do I have to shave my head? The answer is no. Likely they will like trim a little bit of area, but I'll leave that more to Dr. Kusyk. But no, your entire head does not need to be shaved. So the electrode is inserted, and there's a lot of different techniques that are used to control and make sure it is going exactly into the right area. I'll let Dr. Kusyk talk about that a little bit more. This is what that is, basically micro electrode recording. So basically, the surgeon and the team are listening to the brain cells talk back to them to ensure that those electrodes are placed in the most optimal positions. Okay. Okay, and then the next part he wants to explain is that after the electrodes are placed down into the brain part, wires are tunneled and tucked back behind the ear here, and they're just left there temporarily until a patient comes back for the next stage of the procedure, which is a separate day. Then those wires are tunneled down into the chest and connected to the battery pack, and that's the entire system. All right, so a couple of the people's names you might want to be aware of. At UPMC, the surgeon is Dr. Gonzalez Martinez, and his PA is Theodora. And there's also Dr. Ahmed Awad at Hammett. And at AHN, there's Dr. Whiting and Dr. Dorian Kusyk, who is going to be joining us today. All right, so then the actual procedure itself, it's broken up into two parts. So I tell patients very simply, the first part is stage 1, that's the brain part. That's the part where you go in, they put the electrodes down into your brain, put the wires in, tuck those wires in under the skin, and then you go home from that typically. The second stage is where you go in and the battery pack is actually inserted into the chest, and the wires that were tucked behind the ear are connected to the battery pack. And sometimes the battery pack is turned on and sometimes it's not. That just depends on where you are. Where I did my fellowship, they actually turned the battery pack on and they put like mild settings on for the patient. But here I think we just leave it off and it's just turned on once we get to the initial programming visit. So again, brief details of like what is the day like. For stage 1, you go to the hospital that morning, you have your procedure, you stay overnight, and you go home the next day. There is an option of whether stage 1 is performed when the patient is partially awake throughout parts of it versus completely asleep, but I'll let Dr. Kusyk go into details about that. And I'll also ask him to talk more a little bit about like anesthesia requirements so the patients are aware of, do you have a breathing tube, which parts of these, which parts of the surgeries require different parts of anesthesia. Stage 2 is the battery pack day. So you go to the hospital that morning and you have the battery pack connected and you go home that same day. So typically you don't need to be staying overnight. And again, for both of these stages, you would not need to stay any extra unless unforeseen circumstances or unexpected changes occur. And then that would just be reevaluated based on what occurs. Okay, so then patient's big question is, why don't we just turn it right on that day and just start programming it? So the reason for waiting is because there's something called microlesion effect. So when the electrode is introduced, there will be a little bit of localized swelling right at that area where the electrode is introduced into the tissue. What that does is it kind of covers up the Parkinson's disease symptoms for about 4 to 6 weeks. So patients will have the procedure and somehow suddenly all their symptoms are better, and then they're like, well, why do I feel so much better? I don't need my meds, my tremor's gone. And unfortunately that is not permanent. That's called the microlesion effect. It lasts about 4 to 6 weeks, which is why we don't do the programming during those 4 to 6 weeks, because when we do programming, it depends on being able to visualize and see the patient's symptoms, and so that the patient can track in real time while we adjust settings which symptoms are still present and which ones disappear. But if all of the symptoms are gone and they're disappeared, there's really nothing to be able to judge. So we have to wait until this microlesion effect has resolved. All right, and then the first programming visit is where you come back to me here in the office after the microlesion effect is resolved, and then we actually create the settings for your symptom control for your Parkinson's. And that is going to be my next lecture. Okay, and now I'm going to share, or I'm going to introduce Dr. Dorian Kusyk, who is a neurosurgeon at AHN. Go ahead, Dr. Kusyk.
Hello, everyone. Thank you so much for the invitation. Thank you for sort of inviting me for this talk. I think it's a super exciting topic. I'm obviously very passionate about deep brain stimulation. I just recently joined the faculty here at Allegheny General Hospital to do deep brain stimulation for a variety of indications, including Parkinson's disease. Let me just, alrighty. Can you all see my screen there? I got thumbs up, fantastic. Yeah, so very casual talk. This is a sort of a slide deck that I've repurposed from some of my other engagements. For example, the ASSFN logo on the bottom right is the American Society for Stereotactic and Functional Neurosurgeons, which is the U.S. group of functional neurosurgeons that do this sort of work, and I do some outreach work for them as well. Let's see, as Dr. Cardone mentioned, DBS has been for a while, around for a while. We've been doing this for decades. It's not a new technology. I think we're on the 5th generation of hardware at this point, and every time we make it a little bit better. There's currently 5 indications approved by the FDA, but we're focused on Parkinson's disease for this one. And overall, there's over 300,000 patients who've received DBS at this point. So definitely not a new technology. As Dr. Cardone mentioned, it's basically a pacemaker for your brain, and the system looks very similar to that. So we have a target deep in the brain that we want to address, and that's usually either the GPI or the STN. We make a little hole at the entry of the skull so we can access that region. We pass an electrode through that hole to the target using a variety of methods, which we'll talk about. And then we tunnel the rest of the wire to your chest where the battery pack sort of rests. And that's how we affect your symptoms, right? And the reason we do this is because it helps Parkinson's patients live a very much better life. You gain about 4.5 hours per day of on time without dyskinesia, so without those sort of Michael J. Fox motions, the sort of uncontrolled movements from your PD meds. Most people see significant motor improvement in how they move, how they can carry out their activities of daily living, and their quality of life improves. And I always like to collect pictures of my patients. So this is someone I worked on down in Florida, and he's a super athletic guy. Came down with Parkinson's disease in his late 50s, and then he got DBS, and he runs better than I do at this point. And this is really why we do it. And he's really, I always think about him when I try to talk to patients about why we do DBS. But there's a lot of different flavors of DBS, and that's really where the surgery comes in. And as you probably know, every one of Parkinson's disease has their own manifestations of Parkinson's disease and their own medical risk factors for undergoing surgery. And it's all about matching the surgery I do or that Dr. Jorge offers or Dr. Whiting offers to your disease, so we can best match up the technology and the surgery with what's going on with your life and how we can actually help you. So here are some sort of different ways we do the surgery here at AGH. The standard way would be 2 leads at once, come back a couple weeks later for the battery. For some people where we're a little bit more cautious about their cognitive reserve, we might do one side at a time. And then some people just have very unilateral symptoms, and we'll just do that. But regardless, this is all how it starts. Like Dr. Cardone mentioned, there's 2 parts of the day. There's the lead implantation day, the brain surgery part of the day, and then there's the general placement day. For the lead surgery day, you show up in your off medication state. One thing I always tell my patients is always bring your own medications in pill bottles. Every hospital struggles in restarting Parkinson's meds at the very precise timeline you need them to get back on schedule. And you don't need to shave your head. This is purely aesthetic for me. I don't need my patients to do it. We clip just a little bit of hair around where we'll be actually working that day, which is really nice. And there's 3 parts of the day that people tend to remember, and we'll cover all of them, okay? There's the head ring placement, which is whether or not you're doing frame-based or frameless stereotaxy, fancy words, but whichever way you do DBS, there's the head ring. There's the drilling during the surgery itself that people tend to remember. And then there's certain neurologic testing that we do in the surgery to sort of confirm we're in the right spot. So the head ring is the first thing. And sometimes we do this out in the preoperative areas. Sometimes we do it in the operating room itself. This is the worst part of the day by far. And that's not to say the rest of the day is, that's not to say that this in particular is terrible. It's just the rest of the day doesn't hurt at all. But in order to backing up. So we know where we want to put the electrode based on your MRI, but the MRI doesn't know where your head is at any given point, right? So it still thinks you're in that MRI scanner weeks ago. So what we do is we put a frame of reference, a ring on your head that lets us, that we can get a quick CT scan of, which only takes about 5 minutes. And that CT scan isn't good enough for me to know where to put that electrode, but it knows exactly where your head is in relation to that ring at all times. And then by merging the two images, we can know where the electrode needs to go in relation to the head ring. So this is one version of the ring. We like to call it the bird cage. And where you see the red arrows is where it'll rest on your scalp. And it'll get attached with four little screws there. And the screws themselves don't hurt, but it's the numbing medication that stings. Kind of like when you're at a dentist, you get one numbing shot at each of those 4 spots. And that's going to sting for about 30 seconds to a minute. Kind of like a bee sting. It's not great, but it lasts. It only lasts about a minute or so. And then it just feels like a tight hat. Then you go down to the scan and you get a CT scan, which is the right side of this image right here. We merge that with your MRI, and then we know exactly what sort of coordinates to sort of put in. So here are the 4 posts, again, that you had, that you saw in that first picture. And then this is one of the targeting arcs that we can sort of put on top of you like a little hat that we can dial in an XYZ coordinate to know exactly where we're putting this electrode. This is what it looks like in on a real person. So you can see that this person is bald, not because I made him shave, but that's just how God wants him to be. And we've got the 4 posts behind him and a little bit of swelling. And I will say, usually the ladies handle this a lot better than the men. Men are a little wimpy sometimes when it comes to a little bit of pain. The nice thing about this this image as well is you might not see this. I'm going to see if I can highlight this. But this patient actually already had a DBS done a couple months before, and look how well that healed up. This is what we're shooting for. We're shooting for complete stealth neuromodulation, where we spend a lot of time to make sure these implants aren't protruding like little bumps like you've probably seen in the older generations, and that no one knows that you had this done except for the fact that your tremor went away and your golf game got better. All right, so that's the head ring portion. Nothing too crazy there. I don't see any questions in the chat, but we can also open it up later. So then you go to the operating room. And I like to include this little picture because when I put patients in the operating room, I put them in a little bit of that Apollo astronaut position where you're leaning back. You get really padded up, and then we do the surgery. So the surgery itself doesn't hurt, largely because the skull doesn't have any pain sensors, the brain doesn't have any pain sensors, and the skin's going to be really numbed up. A lot of numbing medication we already placed in your scalp for the head ring already is numbing up the top of your head. Once we sort of make incision and get down to the skull, you start hearing what's happening, because kind of like at the dentist when you get your teeth drilled out, it shouldn't hurt, but it just vibrates your skull. And there's nothing we can really do about that. We try to put head plugs in people, and it just makes the noise louder because it's just your head vibrating. But the drilling itself only takes a couple of minutes, about 5 minutes or so. And then I do a little bit of extra drilling where this is the locking mechanism that is usually placed on top of the skull. I do a little extra drilling to countersink this or counterbore it. I had a carpenter tell me that countersinking is an inaccurate description of what I'm doing, but that just makes it flush. Once again, this is probably the second part of the surgery that people tend to remember the most, the drilling, because it's just super loud. This is what the bumps used to look like. And then after we sort of started counterboring the caps, you can see that we've really been very happy about how smooth everyone's head looks like. Once again, the pictures are always of bald men, just I want to show off the bumps, but you don't have to shave your head. All right. Finally, this is sort of the third part of the surgery that people tend to remember, because this is the active participation part of the surgery. Broadly speaking, there's 2 ways of doing deep brain stimulation surgery, and I think everyone in Pittsburgh prefers to do it awake. That's how I do it. That's how I think Dr. Jorge does it. And part of that is because we think we get a better result out of this with your participation if you're helped. because we're trying to implant you with an electrode that lasts you decades, and we really don't want to settle for anything but perfection. So we use a lot of information to figure out exactly where we are in your brain and where we want to place this electrode. So I'm just going to go around the corner here and sort of highlight some of these things. This is all trying to figure out where we are. So when you get your MRI, we often will apply stereotactic atlases onto the MRI that help us visualize the different parts of the brain of greater detail, so we can figure out exactly where we want to go. So for example, for the STN nucleus is right there, so I know I like to place my electrode right around there. We often get other sort of imaging studies as well. So this is, for example, an image of tractography. So this is a newer imaging modality that's been around for the past maybe half a decade or so that actually looks at the flow of water molecules in your brain. And that helps us figure out where the information pathways are of your brain. So we can use that in combination to sort of figure out if we like where our electrode is going to go. But ultimately, these are two imaging modalities. And even if I have the best resolution image, and that doesn't mean that just because there's some gray spots, white spots, black spots in your brain, that doesn't mean that that's where your tremor cells are, or that's where that's the best part for your electrode. So that's why we do this sort of intraoperative testing. So one part of the test is this intraoperative physiology where we're just listening to your brain. And sometimes we have neurology in our operating rooms that help us sort of decipher it because it sounds like a lot of static. But the different parts of the brain have different elements of static. And this is recorded with a super tiny electrode that's maybe 0.8 of a millimeter thick. This is sort of like a listening wire that's not as thick as the final wire we'll put in. And then we basically, in our mind's eye, have a sense of like, okay, well, we expect that at 10 millimeters away from target, we'll hear this sort of noise change. Or at 5 millimeters away from target, we'll hear this noise change. And we compare that to what we're actually listening to. Simultaneously, we can also look at things like local field potentials, which is a sort of fancy sciencey word for this the summation of all the electrical activity of your brain. And we're just confirming that we're in the spot that has the pattern of electrical activity that we want to see and that we associate with good results. Using that tiny listening wire will also sometimes give you little bursts of stimulation in the operating room. This is basically us acting, using stimulation as a little sonar. You know, your brain is a very densely packed organ. There's a lot of stuff going on there. We want to make sure we're in the spot that gives you the best results, but we're far away enough from places that might give you some side effects. So depending where we are in the brain, that side effect might be a little difficulty of speech. That might be a little numbness in the hand. That might be a little cramping in your fingers or something along those lines that we don't want to see long-term with the stimulation. And so we give you little test pulses where we're sort of feeling out the boundaries. And we know in our mind's eye, that maybe, if we go up to 1 milliamp of stimulation and you're getting side effects, that's a little too close for us. So we might move that electrode 1 millimeter over or 2 millimeters over. And that's something we really get to do because you're awake and you're talking to us through the side effects you're feeling that we can't do if we just put you to sleep. And this is sort of the picture of that, where we want to stimulate the sweet spot, but we want to be far away enough from the sour spot. And while we're doing all that, we'll be testing you and doing the sort of same exams that you're probably all tired of doing in the neurologist's office. Little finger tapping, hands open, moving around. We're testing your rigidity. We're seeing how your tremor is reacting, things like that. Once we have a satisfactory sort of sense of where we are based on the listening wire and all that information, and none of this information trumps everything else. So we're looking for agreement among all these information sources. We'll put the final electrode in, and then each of the electrodes have about 4 levels of stimulation that we can then test for the same sort of thing, where we're looking how close we are to your sweet spot and how far away we are from your sour spot before we lock it in. This is a lot of information. I will say a lot of my neurosurgery residents, my trainees, also struggle with all this. So I wouldn't expect you to, understand it, but just know that There's a reason why we like to do this surgery awake, because I think we can do better with your collaboration. And there's a lot of information that goes into designing the perfect electrode for you, because everyone's a little different, okay? Now, I included this video here, and I'm not sure if the sound's going to play, but this is actually recordings from the thalamus, and you can hear closely the changes in this static. So I'm not sure if that came through, but basically every time our neurologist was touching this patient's thumb, the tone of the static changed, and that told us that we were close enough to the sensory cells. Okay, that's something we do more for essential tremor than for Parkinson's disease, but that sort of symbolizes the sort of what we're doing with that awake testing. All righty. So that's it. You stay the night with us. And then people usually go home the next day right after breakfast. You might feel a little sort of nappy afterwards, but we'll talk about that. And we don't usually have two main limitations on patients. You usually go home the next day. People usually manage this sort of pain, just the postoperative pain, with some over-the-counter medications, but we send you home with some stronger stuff. And I would say 80% of my patients never need the stronger stuff. Usually we close our wounds with staples, and they come out in about 2 weeks, and we let you shower 2 days after surgery, and then just keeping it clean, dry, and open to air afterwards. I did a lot of my training in Florida, so we had a lot of snowbirds, so we always had to tell them to not just fly out of the country or fly to a different state during the week after surgery. And there's no strict limitations on driving, except if you're taking the pain meds we're giving you. And then really tolerate any activity as you're tolerating, but you're avoiding sort of any heavy lifting or strenuous exercise, largely because I don't want these sort of wounds to be sweat too much, but walking is great. As Dr. Cardone mentioned, there's that sort of temporary swelling, that micro-lesioning effect, and that's expected. Your brain doesn't like having an electrode in it, so there's always going to be a little swelling around it. And there's really two sides to that coin. There's that honeymoon effect, that you might feel your tremor, your symptoms are better even without stimulation. I've seen that last up to 6 weeks. Usually I would say it lasts about 2 weeks or so. But people feel great. It's a rush. I don't promise it to everyone, but it's great when it happens. The flip side, though, and I'm not very creative, so I just call it the anti-honeymoon effect, is that sometimes that swelling will get into those same spots we were trying to avoid with stimulation. So you might have a little difficulty with speech. You might have a little difficulty with swallowing, balance after surgery. And so that's part of the reason before surgery, we really want to work you up with physical therapy, with speech and language pathology, maybe doing some swallow studies. We just want to know, if this were to happen, what sort of risks you're looking at. But in the same way that the honeymoon effect usually just lasts a couple of weeks, these sort of effects also just last a couple of weeks. Then depending on sort of the staging we talk about, you'll come in for the generator placement. And this is a much less exciting surgery. This is, I like to say, it's just skin surgery. We're not going inside your brain whatsoever, but we access the wires that we left behind, as Dr. Cardone mentioned, and we connect them to our pacemaker, which we usually put on the right side. I will say some of our patients like to go shooting with rifles, so then we put it on the other side. We talk about that where you want it based on your hobbies. This surgery, you don't need to hold your medications. You'll be under total general anesthesia, and you go home same day, okay? And as Dr. Cardone mentioned, sometimes we send you home with some baseline settings. Usually that's sort of the honeymoon period, that sort of swelling around the electrode makes it a little difficult and really easy for us to overshoot with stimulation. So sometimes we just wait until your first programming visit to sort of get that done. The big decisions that you have to make at this point is whether or not you want a rechargeable battery or a primary cell generator. So this is just one company's example. But basically the rechargeable batteries are smaller, thinner, but you might have to charge them for about 30, 40 minutes once or twice a week. And that charging looks like a little, almost a scarf situation where you have a counterbalance and then like a little remote charger that you lay on your chest. But But those batteries last 10, 15 years. So that really saves you any sort of repeat surgeries down the line. And it's very user-friendly. The older technology is the primary cell, which is just a standard battery. It's really good for patients who can't be bothered to recharge, or they just don't have that capacity, or they really want to set it and forget it. Those last maybe 2-3 years, depending on your programming settings, and then would need to be replaced. Each of these technologies, and this is something that they'll talk about your next month's webinar, every technology has its own sort of perks. Medtronic does adaptive DBS, which has recently been FDA approved. Boston does image-based programming. Abbott does remote programming. This is something that we spend a lot of time in our clinics sort of talking to you about to try to figure out what's most important to you and what's the best fit for your symptoms. So it's really just choosing about the technology that best suits your needs. Just to sort of wrap things up, we already talked about who's a really good candidate. 3-4 years of disease, the more you respond to levodopa, the better you'll do with DBS. The only exception is tremor. Even if your tremor doesn't improve with Parkinson's medications, DBS can help with that. If you have prominent on and off fluctuations, if you have dyskinesias, if you have dystonias, DBS can really be useful for that. And then overall, if you're just a sort of patient that's taking carbidopa, levodopa more than 3, 4, 5 times a day, just to try to keep a handle on the fluctuations of you, this might be something to talk to your neurologist about at that point. And if you have any questions, you can always schedule a visit with me or send us an email or anything like that. I think that's all I have for my slides. I have more pictures of bald men with surgical scars, but that's about it. Any questions? That was a lot of me talking. It's a lot of sort of high-level information, but I try to sort of demystify the surgery process and answer any questions you might have at that point.
Thank you, Dr. Kusyk and Dr. Cardone. You're welcome to unmute yourself and ask the question or type it in the chat.
Thank you so much, Dr. Kusyk. That was really amazing. Really broke it down very straightforward so people really know what the whole entire beginning to end procedure is.
Absolutely.
Yeah, no, thank you for having me. We didn't talk too much about, there are people out in the United States who do asleep Parkinson's DBS. And for that, it's a different sort of strategy. You focus a lot more on the imaging for targeting, but then you do go fully asleep for that surgery. For super anxious types, we do offer that as well. But I will say, I do think every time a Parkinson's patient goes under general anesthesia, it takes a while to bounce back. And so I try to avoid general anesthesia for my patients whenever possible. Sorry, Casey, you're muted.
You're right. Thank you. There's a comment about some flare earplugs. Maybe that could help to reduce drilling sensory sounds.
Yeah, I was working with an engineer to try to figure that out because there are those sort of cool sound canceling earbuds. I worry because it's bone conduction, and our initial test weren't very optimistic. But we're looking for answers. We really are.
Order a pair for yourself, see if you like them, and go from there. There are a couple different kinds. They fit inside the ear a little bit, and they're designed to compress the hairs in the ear. So that would probably reduce some of the effect that's felt during drilling. They're hollow, so sound will still move through, so it won't be like creating a cave.
Yeah, I wonder because the drilling conveys the noise because it's not vibrating the hair, it's vibrating the bones itself. Bones. So I feel like I should get some of those and then time it with like the next time I'm at a dentist to sort of see.
Absolutely. Yes. Yes, but I think it would probably help post-care. I found them useful after a car accident, so I wasn't handling sound very well. I ordered a pair of them, and it was a whole new world.
Fantastic. No, thanks for the advice. I'll look into those.
Yeah, thanks, Christina.
Sure.
Oh, here's a question. What is the duration of the effectiveness of DBS?
Yeah, no, that's a great question. And I think I can give you the neurosurgery standpoint, and then Dr. Cardone can give you the neurology standpoint. I would say that DBS never stops working, but your disease keeps getting worse. So at some point, your disease will progress to the point where it feels like you're back to where you were, where you finally got DBS the first time around. But that's not because the DBS stopped working. It's because the Parkinson's disease has sort of gone to that level. And if you turned off your DBS, you would be much, much worse. I do some revision surgery. Sometimes that's necessary as the disease evolves. I've had patients who were initially very good targets for, let's say, the GPI target because they had a lot of dyskinesias, and then they developed bad Parkinsonian tremor. So then we would offer them a second surgery to capture the tremor with the STN surgery. But I wouldn't say that's very common. Usually people just get one surgery, and then the rest of it is usually just battery replacements if needed.
Yeah, basically. The first thing I tell people, like when we're talking about DBS, that it's permanent, it's in there for the rest of your life. It's adjustable for the rest of your life. So yes, as your disease progresses, your symptoms will change and progress. We would just keep adjusting and adjusting and adjusting indefinitely. The technology that's out there today, you can basically have an infinite number of combinations, an infinite number of programming creativity that can just go on forever, basically, as and when symptoms change and worsen. And agree, the only time that I've seen revision surgery is if a lead is implanted and we clearly do not have any clinical response. We would have the patient be reevaluated by the surgeon for lead revision surgery. And then again, what Dr. Kusyk said, if you have totally brand new symptoms that crop up, and you need a different lead in a different site to target different symptoms. But yes, it's permanent and it's there forever. Then the next question is, does it work better for stiffness and immobility or for tremor? Which examples are most indicated? Oops. Okay, which does it work better for stiffness or immobility or tremors? So the old school of thought was you were only supposed to get DBS if you had really bad tremors and your tremors were not getting better with medication, but that's not true. So we do know now that it's highly useful for patients who have bradykinesia, which is slowness, stiffness, rigidity, shuffling of gait, freezing of gait, and tremors. So I like it for all of those things. The freezing of gait, I found there's new technology now, again, Medtronic versus DBS. There's an adaptive stimulation that we have found to be very helpful for patients who have freezing, because freezing is a momentary surge of your PD symptoms. And during that surge, if you get a boost of stimulation, it helps to overcome that freezing. So we've found that very helpful. And then, yes, the tremors are sort of the easiest to control with the settings and with the capabilities. Which examples are most indicated? So I tell, if you're my patient, if I have met you and if I know you're going to be a DBS candidate, I tell you that at the very first visit. So any of my patients who meet those criteria, you're taking medications multiple times per day, you're having wearing off of symptoms, you're having poor quality of life, you're having anxiety, shortness of breath, stiffness, freezing of gait, increasing your risk of falls when you're in your off state. You get up and go to the bathroom overnight and you're unmedicated and you're falling or having a risk of falling. Any of those times is when I would be discussing DBS with you from the get-go.
Yeah, and I would agree. I think anything your carbidopa, levodopa does for you, DBS can do consistently. And then tremor and dyskinesias are things that even if your carbidopa, levodopa doesn't help with, we can help with as well. But if you're even thinking about like, oh, am I a candidate or something like that, just have a conversation with your neurologist or neurosurgeons. Like, we have a lot of discussions with patients about what DBS is. We do a lot of education during those visits. And I would say for a lot of patients, you just hear about it and then it takes about like a year or two to wrap your head around the concept of brain surgery. And then you'll be ready to discuss it again.
Which is that's why I bring it up at the first visit, because every time I bring it up, it's slightly less and less intimidating.
Yeah.
There was one other thing I was going to say. I'm not sure.
Hmm.
And then I think that's a question for you, Dr. Kusyk. Are you doing assessments, and how do you calm the nervous system before measurement?
Is this a question about when I do assessments during the surgery or before surgery?
Before and after, more after.
Okay. So, so during the surgery, we have a team. I sometimes partake with the assessment. Sometimes the neurology does. Sometimes one of my PAs will be sort of running you through the classic sort of motor exam things. Ultimately, we spend a lot of time in the operating room trying to create a very calming environment as much as we can. It's going to be scary. It's a foreign experience for a lot of people, but people bring their own music. Someone brought their own playlist and they called it like songs to get your head drilled to. Still
Okay.
comes up on Spotify. Sometimes we have the TV set up where you can sort of watch some nature videos or something like that. We're not quite set up here at AGH, but where I did my training, we actually had a camera that was focused on the incision, and some people really like to watch it. And that sort of took the mystery away from it. But it's really about sort of talking to you and what would make you feel more comfortable. One of my partners actually pulled some strings, and the patient really wanted to listen to classical music, and we were friends with like the first chair from the symphony, and so he came into the OR and started playing violin music for the DBS patient. That was a super cool experience. Not sure we're going to do that consistently, but we really try to just create it as calm of an experience as possible. And the other part of it is that the people you'll see a lot of new people during the operating room, during the OR. But at least half of them you've seen before, because you'll have seen, most likely, you've seen me, obviously, or your surgeon. The PAs are usually consistent. So the clinic PA comes into the operating room and holds your hands and like talks you through the process. We also have a nurse that sort of helps with that process as well. So there's a lot of sort of familiar faces that we think helps ground the experience. But it's scary, and we try to do it the best we can. The other thing I do that is inconsistent among some of our partners here is I do give a little bit of sedation during the surgery itself before we do the sort of awake participation bit. It's called Presidex. It's not enough to sort of get you to the point where you need a breathing tube or anything like that. But a lot of people just feel like it takes the edge off, and it makes people laugh at my jokes a little bit more, which is nice. I think it's important for me. But so we do a lot of that for how to keep you calm during the surgery itself.
To answer your question about in the before and after stages, if you're my patient, you'll know I'm pretty aggressive about evaluating for anxiety, treating your anxiety, and if you deny that you're anxious, but I still feel that you're anxious, I will tell you that, and I will tell your spouse that and your support group people with that, and by the end of the visit, someone will have convinced you that yes, you need to get a little medication and or talk therapy to get you through the procedure, and that's all. That can be temporary, and I have found that after I started doing that, after doing this for a longer and longer time, the people who are on a little bit of medication to help their nerves calm down for a little bit before surgery end up doing better overall. They get back to their normal self faster. They bounce back a little bit faster too, because we live in Pittsburgh and there's no sunlight here, and that affects mood, and that is unfortunately the reality. So I do make sure things that like anxiety and depression are well controlled, even if a patient does not believe or acknowledge that. I do the best I can to make sure that that's controlled to my satisfaction before I let you go.
My other question, more about measurement assessments for post measurement to see how they're doing. I was wondering if you are lowering their anxiety or stress before the test for more accurate measurements.
Sorry, wait, before which test? In the surgical procedure, or?
No, are you testing afterwards, like for the programming part?
Yeah.
So I was wondering if you are doing anything to regulate the nervous system before the programming so that you'll get better results during programming.
Yeah, but I already did it before.
Oh,
and I adjust that dose if it needs to be adjusted. But yeah, it's already done before. I don't let people go in anxious. I don't want them coming out anxious because, yes, it muddles the clinical response. And
right.
if a person has a tremor and they're really shaky, sometimes if they're too anxious, they're shaking because they're anxious, and then I can't tell what that is. So I make sure that's all under control before.
How?
Usually with medications, but also talk therapy, and I make sure they have access to support group. But to be truly honest, a little bit of medication goes a long way. Medication that works on the dopamine pathways itself. I typically favor Zoloft because I think that does the best job for my Parkinson's patients in terms of giving them a boost of energy, but also reducing anxiety levels, and they feel a little more even keeled, and then it's easier to program after.
Have you ever thought about using an art therapist to do that job for you rather than talk therapy or medications?
Absolutely. If you're willing to come to my office, you're welcome to come here once in a while and sit down and talk to patients, because I'm willing to use anything that they like and that helps them feel calm.
Okay. Well, more to come on that.
All right. That sounds good. Yeah.
Thank you.
Thank you.
And a nice kudos to Dr. Cardone as a patient of Dr. Cardone's. She does an excellent job of getting her patients prepared for surgery.
Thank you. Thank you so much. It's my job. Thank you.
Any other questions? Well, thank you. This was very educational, and thank you, Dr. Cardone and Dr. Kusyk, for providing both perspectives.
No,
Thank you.
This was
Thanks,
a lot of fun.
Thanks for taking your time out of your day, Dr. Kusyk. I really appreciate that.
No,
Yes, thank you. And you too, Dr. Cardone. Okay, one more. Will we have one more part to this series, or?
There will. I have to talk to you about a date, though, because
Sure,
it might have
no
to change. But I will talk to you, and we'll get the word out.
Stay tuned for the final part of the series. Thank you, everyone.
Thank you.
Bye.